Hello, friends. So, the part of the World Sepsis Day campaign, and we are in the World Sepsis Day week. So, I'll be giving a brief overview on this sepsis chain of survival. So, this came as a uh, publication as part of the World Sepsis Day from the World Congress group. So, just a new concept for all the trainees to know. So, the conceptual understanding of chain of survival. So I'm sure you may have heard of this chain of survival in cardiac arrest and chain of survival in stroke patients. So similarly on those lines, so they have put in certain components to call as chain of survival in sepsis. So there's no rocket science in this. It's just putting the salient aspects together in the whole dimension of sepsis. So when you talk about chain of survival, it is looked at as a metaphor which initially was coined by American Heart Association to improve and enhance the survival in cardiac arrest patients. So that is where this whole concept of chain. Like if you look at today, where there is a ACLS protocols and the ACLS algorithms or basic life sciences algorithms that are followed. So they all constitute chain of survival where certain things have to be done concurrently in a time bound way to improve the survival in these patients. So that's what we call as chain of survival. So, and these, when put together in a very synchronous way, they are meant to improve the survival in a patient. So, what do you mean by chain of survival? There are interdependent interventions. So, there are certain interventions that are meant to be done in a time critical way to optimize the survival. And these interventions have to be seamless. When I say seamless, there should not be too much of interruptions when you're putting, like typically you envision the cardiac arrest scenario where we at a spinal level do certain things in a synchronous way, in a seamless way, in a time bound way, so that we improve the survival. So same principle is applied to the sepsis chain of survival, and it has to be time critical. So when you look at the typical conditions where this chain of survival are put, they are generally life-saving sort of a clinical conditions where we put this chain of survival. So cardiac arrest is the most commonest one where we put the chain of survival sort of a events to improve the survival. And stroke is another because door to needle time to have an effective way of thrombolizing so that we improve the morbidity is also an important chain of survival. And polytrauma. So I'm sure like ACLS, we have advanced trauma life support where we put certain sequential steps in place to optimize the survival in polytrauma patients. And PPH, maternal hemorrhage. Here also the time is gold because we cannot waste time, and we call it as a code. We call it as a PPH code is something that has to be put in place so that we save the life of mother by putting in certain steps. So chain of survival is on all these life-threatening situation and anaphylaxis and asphyxia in children. So these are all life-threatening imminent conditions where if we do not do certain steps in a time-bound way, the chances of survival gets diminished. So that's what it means. So we have tried to put this similar concept into sepsis to optimize the outcomes. So this is a conceptual sort of a note that came out as to what are the key elements that may be important. So again, as I said, the steps are interdependent, but not necessarily linear. But all the steps that are put in place are meant to be considered either in sequence or concurrently to enhance the best chance of survival. And if missing out on any of these steps at any point has a bearing on reducing the survival in sepsis patients, and so is the case in any other clinical condition. So let's look into what are the components that they have put in place as the chain of survival. The first one, see, in sepsis, the main lacunae is in our ability to recognize and identify at a community level. So the first chain of survival they put as awareness. So the public and the community need to be aware that there is a condition called sepsis and means and ways to prevent the sepsis, like good sort of a hand washing, sterilizing techniques, and disinfection, so on and so forth. The second one, which is of utmost importance in the healthcare setup or in the pre-hospital setup, is early recognition for sepsis. Early recognition and calling for help when you have a patient with sepsis is the second chain of survival. And the third thing, which is of utmost importance, even at an ICU level, is try to relentlessly pursue to identify the source of infection, because unless you address the source, the outcomes of sepsis cannot be bettered. So it is imperative and important that the source is identified early on, and the source, like if it is a UTI with pyelonephritis, digestion has to be put in to drain the pus, or if it is abdominal sepsis with a inflamed gallbladder, then a source control has to be achieved, so on and so forth has to be done. So if it's a skin and soft tissue infection, so debridement has to be done. So actively look for the source control. And the fourth one, which is again of importance for intensivists, is give oxygen for all the sepsis patients, optimize oxygen at least, give fluids and early antibiotics, which you all have heard. But oxygen, if you see early surviving sepsis guidelines, oxygen did not find a good mention. But here there is a good mention that oxygen, because most sepsis patients have relative hypoxemia, and they have to be supplemented with oxygen. And they would be tachypneic, they may need fluids, and they would need early antibiotics, preferably within 1 hour. So those are the four, and there are six. Basically, there are six links. The fifth one is the critical care functionary without walls. So what this essentially means is, don't wait for advanced sort of a tools to start optimizing the patients. It means if you have identified a patient, even in the ward, so don't wait for the patient to be shifted to ICU for you to incorporate the steps to optimize the patient. That's all it means. I will talk about it. So that's what it means. So whatever are the available facilities, whatever is available tools, don't say I don't have ultrasound, so I can't assess volume response. Whatever tools you have, try to utilize that and start optimizing sepsis is the one. And the last one is post sepsis care and return to cup, because it has been increasingly recognized. There is a separate video you can go and watch, which I've done on post intensive care syndrome. So post sepsis syndrome has an important bearing on the morbidity, and they have found that significant proportion of the patients who get discharged after sepsis, within 1 year, they may have died, significant proportion of the patients. So there is a distinct entity called post-sepsis syndrome or post-intensive care syndrome, which one needs to bear in mind and try to optimize the conditions if they have those elements of post-intensive care syndrome. So these are the six components which constitute the chain of survival. So we'll just try to tease out each one and see how is it elaborated with regards to what we mean by sepsis awareness. So sepsis awareness is like we had World Sepsis Day on 13th. So it is our onerous responsibility to get the public to understand and have a training session, get people to understand sepsis as a very important killer, because the number of patients sepsis kills is more than the patients who die of heart attacks or acute coronary syndromes, and it is more than patients who die of strokes or who have strokes. So sepsis is a lethal, and every 3 seconds globally one patient dies of sepsis. So educating the public, educating the healthcare personnel on the sepsis becomes important. And importance of these three elements at the community level, which I'm sure we have been reading about it from MBBS days: good water, good sanitation, and good hygiene. Emphasizing on these three become quintessence as steps to avoid and prevent sepsis. And the role of vaccinations, because increasingly there is an emerging role of adult vaccinations and vaccinating the vulnerable population, especially the elderly patients, against pneumonia, against the flu. So all this goes a long way in mitigating the sepsis. And good infection control practices has to be practiced even at community level. Uh, Good hand washing, good disinfection, and meticulous infection control practices goes a long way in preventing sepsis at a community level. And public health campaigns about this condition, because when we did the World Sepsis Day on 13th September, where we released a special postal cover, a lot of media people came, and trust me, friends, none of the media knew what is sepsis. So we had to explain to them what is sepsis. So it is, I think the time has about come where we start campaigning that this is more lethal condition than heart attack and strokes. And we are the ones who need to educate the public about the gravity of sepsis that is killing more patients than heart attacks and strokes. Friends. So I think as a part of World Sepsis Day, it's important that we all engage in public health campaign as an intensive care community would be my earnest submission. So the second one is early recognition and call for help. So even if you look at the guidelines, it says we have to constantly screen the patients who come to the hospital for a possible sepsis. And you may screen 10 patients, at least one you may be able to pick up who may have a signs of early sepsis. And continuously one needs to reevaluate the patient when they come to hospital and search. And if you are unable to explain that this condition is due to sepsis, then only alternate diagnosis has to be entertained. And of course, when you have started antibiotics, considering that there is an infection, at least when alternate diagnosis is entertained as non-infectious, one has to stop antibiotics. This is terribly important because studies have clearly shown if you are continuing antibiotics in a patient, calling it as sepsis, and where there is no sepsis or where there is no infection leading to it, and there is a non-infectious cause, the mortality also goes up if you are using antibiotics indiscriminately. And there are significant proportion of deaths that happen due to antimicrobial resistance in sepsis. That's why there is an emphasis on judicious usage of antibiotics. That also becomes a part of chain of survival. And as I said, community participation and healthcare awareness. So training the community, training the healthcare personnel on tools and the cues that they need to know to recognize sepsis and have an action plan and public health campaign, and try to explain to the community about certain danger signs, especially in vulnerable population, certain alarms that they may need to be aware, for which they need to seek healthcare sort of a consultation has to be emphasized. And early detection and training the healthcare personnel on protocolized management of sepsis goes a long way in the chain of survival, has what has been emphasized. And when we say protocolized management with an emphasis on three aspects that emphasis has been given. So any patient with sepsis, consider oxygen, fluids, and early antibiotics at the outset. And then once you have got an answer on the type of infections, you have to de-escalate the antibiotics. And the third thing is the continuous source control. Even if you look at the surviving sepsis guidelines, once you have labeled a patient as sepsis, within 12 hours, in your mind, you should have an answer. What is the source of sepsis? Because I remember many a times, even in our team, our trainees get lost because I had recently a chronic liver disease, and they were treating it as a pneumonia as a possible source when she was on no oxygen. So I think these are, although we think these are all simple things, but people have to put in their mind and say, what is the source of sepsis? Because you should have an answer. At the end of 12 hours, you should say, this is a patient with sepsis, and the possible source is gut translocation or urine, so on and so forth. Don't say it's a pneumonia when someone is on a room where comfortably breathing, not even tachypneic. So this is something which we all have to ingrain into ourselves, into our intensive care community. Try to identify the source by putting your clinical acumen in place, and that gets a strong recommendation. And even if there is a abscess, so if an intervention has to be done, you have to consider an intervention which causes least physiological upset, and it should not be delayed. That also gets a good recommendation. And if you have an infected catheter, which is not uncommon, especially if you're an oncological patient or someone who is undergoing regular dialysis, so the catheter, if it looks infected, that has to be removed. So basically, this whole chain of survival talks on relentlessly pursue to find out what is the source of infection and address that source is the way. So the fourth one is appropriate fluids, oxygen, and antibiotics. So early antibiotics, we have spoken enough and more. We know how important it is to give antibiotics preferably within 1 hour and administer oxygen. This has been emphasized, which possibly has been downpedaled even in our guidelines. So there is an emphasis on giving oxygen for all the sepsis patients, and fluid resuscitation guided by the principles of fluid resuscitation by static and dynamic. More often we follow dynamic sort of a tools to ascertain the fluid responsiveness. I'm sure most intensivists are adept and good at that. So follow the principles and start fluid resuscitation. And these form the foundational components of surviving chain or the sepsis chain. So then coming to the fifth thing, the ICU without walls, which I've already said. So basically be flexible and don't say the patient has to come to ICU to initiate the treatment for sepsis, and use highest quality care with available tools there. And all these have to be time-bound critical interventions with the available resources. If X-ray is there, utilize X-ray, identify pneumonia and start treating. Don't say, I don't have an ultrasound, so I'm unable to look into the A profile or consolidation or A fusion, so on and so forth. And there has to be coordinated efforts, and the whole healthcare system has to be sensitized to the possibility of sepsis, so that there is a continuum of the treatment, and the steps to treat the sepsis have been put in place. And when we say continuum, it even extends to out of hospital. So it even extends to pre-hospital optimization of patients with sepsis, which means even the paramedical staff or the ambulance staff also have to be sensitized on certain optimization. At least give oxygen, at least give some fluids, and even you can administer antibiotics when patient is being transferred from one place to another with sepsis. When I say one place to another, people come from different places into the city or between two different towns. So optimization has to continue during the travel. Even the pre-hospital setup is what has been emphasized. So, and the survival chain, the sepsis survival chain talks about community collaboration, healthcare personnel collaboration, emergency medical services, and even collaborating and training the healthcare clinics and the referral hospitals on this whole science of sepsis to improve the outcome and improve the survival has been emphasized. And this collaboration between the emergency ambulance services, referral doctors, and community has been put in as a very crucial sort of a dimensions that one needs to embrace. So coming to the last bit, so we finished the 5 survival chain of sepsis. The last one is post sepsis care, because increasingly it is recognized you may treat the sepsis, send them to ward and send them out and be very happy, but it has been found that significant proportion of them are left with debility and severe morbidity, which impairs their normal functional quality of life, and many of them can even die within 1 year. So there has to be some optimization even after discharge. So there is a focus on improved rehabilitation to improve physical function. And post sepsis care involves 4 components: optimizing nutrition, optimizing physiotherapy and exercises, and optimizing certain post sepsis sequelae that this patient may have. Try to look into the sequelae and manage. Most importantly, psychosocial support, because there's a lot of psychological impairment or psychological disturbance that these patients have, which seldom gets recognized, and they need to be addressed. And it has been shown that post sepsis, one has to do certain scoring to look into their cognitive function. There is a hospital anxiety depression score and impact survey, so on and so forth. Try to look into the cost ramifications of these problems and offer psychosocial support for this, and try to create support groups if they are affected psychologically or cognitively, and have multiple counseling sessions. And it is shown that after sepsis, patients can have physical impairment, can have cognitive impairment, can have psychological impairment, and all this can be compounded by your financial deprivation also. Even the lack of, even the financial loss that they would have incurred during the treatment of sepsis has an enormous bearing on their overall well-being. And these are all the different triggers that is encapsulated in this picture. The increased severity of illness or death also has a bearing on the sepsis patients, and financial deprivation and low level of education, lack of social support, lack of communication. All these are the triggers for increasing the severity of post-sepsis syndrome. And job loss, financial deprivation, all these can be common things which can trouble the patients even after post-sepsis. So the conclusion, friends, of this sepsis chain of survival is an attempt to call for an action as an integrated action from the community, healthcare personnel, and the hospitals and the pre-hospitals to put in systems in place so that the optimizing the survival in sepsis patients become feasible. And this is a call to action to all the global healthcare personnel for putting an integrated and systematic approach for the sepsis management, which is contextualized at the local level. So the action plan pretty much summarily involves 4 steps: mainly public health campaign and adequate training of paramedical, pre-medical, and ambulance services, and hospital personnel and ICU physicians on certain protocolized management of sepsis and making them aware of different components of sepsis and the chain of survival, and train and retrain on the protocols and have a nationwide protocol so that everyone follows that protocol as a bare minimum in addressing the treatment of sepsis, and have adequate resources allocated for the survival chain of sepsis, so sepsis survival chain, and strengthen the healthcare systems at the hospital level, pre-hospital level, at the ambulance level to optimize the outcome in sepsis. So this is the gist of sepsis chain of survival, and all this was put in place as again a campaign for the World Sepsis Day 2025, that we have come out with sepsis chain of survival so that we create more noise and have the systems in place at hospitals that they are recognized early and appropriate protocols are put in place to optimize good outcome in these patients. So that's about it, friends. So thank you one and all. So request you all to submit your valuable work to Journal of Acute Care. You can visit my website to react to this. So this can be asked as a DRNB question or DM question. So please go through this sepsis chain of survival. At least you have to remember those 6 components that you need to put and then elaborate on it. So that's all it is. If you have not read, you will not be able to answer this, friends. So thank you one and all.